Hi, this is Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. And today I would like to welcome you to the Journal Club for the March 2025 special issue. I'm really excited, obviously, to have this discussion, and I'm really excited to hear from our guest editors. I also like to thank ESGO and IGCS for their support in our Journal Club. Before we begin, I want to mention a few housekeeping notes relevant to the Zoom platform for today's Journal Club. We're recording today's discussion, and the recording will be made publicly available. Participants with the camera turned on may appear in the video recording, so please be cognizant of that. We ask that everyone please keep your microphones muted so everyone can hear the presentations or the discussions. And if you're having any difficulties or questions, please send a message in the chat to our technical support team. We definitely want to encourage questions, and we want to encourage discussions. So please also submit your questions via the chat function for today's session. So, of course, as I mentioned, this is a special podcast for the special issue of March 2025. Titled Controversies in the Management of Rare Gynecologic Cancers. And I want to thank our guest editors. They did an amazing job, a really, obviously, a very recognizable task in that it's always a challenge to find all of the contributors to the special issue, to getting everything in time. So we're really, really glad that they have participated as guest editors, and we have a really great issue this March. So first, David Gershenson from the University of Texas MD Anderson Cancer Center, Jonathan Ledermann from the University College of London, and Isabelle Ray-Coquard from Medical Oncology at the Center Léon Bérard in Lyon, France. So delighted to welcome all of you for our discussion. David, Jonathan, Isabelle, thank you so much for being with us today, accepting our invitation. And then also today, our attendees and fellows will have the opportunity to ask specific questions regarding these topics. So with that, I want to welcome all three of you.
Thank you. Thank you. Pleasure to be here.
Thank you, Pedro.
Absolutely. Thank you all. So we have prepared some questions from our fellows, and I think the first question is going to be from Kira Fisher, University Hospital in Heidelberg. Kira, please go ahead and ask your question.
Yes, thank you very much for this opportunity. My question is concerning the significant differences in treatment outcomes between the male and female germ cell tumors. Is there any hypothesis on what specific biological factors contribute to the poorer prognosis of relapsed malignant ovarian germ cell tumors compared to their testicular counterparts? And if so, how could this knowledge maybe influence future therapeutic strategies?
Thank you so much, Kira. I'll direct our first question to David Gershenson.
Yeah, thank you very much for that question. Let me preface it by saying, to remind everybody, that this special issue is dedicated to Michael Frumovitz, one of my colleagues and a friend of all of us, who passed away in July from pancreatic cancer all too soon. We do say a few more words about Michael in our editorial that accompanies the articles in the special issue, but he was really an amazing person, and we think about him every day. So to answer your question, it's important to point out that testicular cancer is 10 times more common than malignant ovarian germ cell tumors. Consequently, many of the principles that we've learned over the last few decades have been extrapolated from the knowledge in testicular cancer. And as Seckel and colleagues point out in their article, brothers of affected men with testicular cancer have a 10 times risk of developing the disease compared to controls. Because of this rarity, because of the rarity of malignant ovarian germ cell tumors, we know a lot less about the heritability of these tumors. We know that there are certain cancer susceptibility genes that have been identified in testicular cancer as well as malignant ovarian germ cell tumors. And there have been some certainly reports of women with 46XY or Turner syndrome having an increased risk of developing malignant ovarian germ cell tumors. In testicular cancer, they've identified a number of aberrations, mutations in KIT, PI3 kinase, and WENT. But these gene aberrations or mutations have not really translated into better therapies at this point. But I think we will continue to learn from testicular cancer and hopefully can develop much more novel targeted therapies. Although, as we know, chemotherapy is a very, very good treatment for most of our patients.
Excellent, David. Thank you for that perspective and starting that discussion on the germ cell tumors. And you mentioned a little bit about the standard recommendations as it pertains to chemotherapy. Anything on the horizon as it pertains to targeted therapy that seems to be effective and it seems to be strategy that will become standard in the future in terms of what we know about germ cell tumors today?
Great question. I will defer to my colleagues, but here's what I would say. I think the short answer to your question is not yet. I would say the emphasis right now, based on an international trial led by the Children's Oncology Group, is to lessen the radicality of treatment and to triage many more girls and young women with the malignant ovarian germ cell tumors into a surveillance or observation mode rather than treating them automatically with usually with BEP chemotherapy. I think the other somewhat different approach, and I do use this for pure dysgerminoma that's metastatic, is etoposide and carboplatin rather than the standard BEP regimen. But I'm not personally aware of any really promising targeted agents that have been studied, but maybe Michael, I'm sorry, Jonathan or Isabelle may know.
Yeah.
I just, if I could chip in, just not actually with a new drug, but to say that I just wonder whether one of the factors that might affect the differential outcome is, as David said, it's a much rarer tumor, and therefore experience is much less. And I think many of the testicular cancers are treated in regional centers where there's a greater experience or greater volume, I should say. And I just wonder whether that is the case in the female germ cell tumors, and I doubt it. And so that physicians who are treating these tumors may really, apart from certain big centers, may really have less experience, and that may impact on the outcome of the disease.
Well, that's an important point, Jonathan. And we all know that the UK and the EU do a much better job of that than we do in the US.
Isabelle, you had some comments.
Yes, just to add, because I fully support what David and Jonathan have said, I would like just to also mention the fact that the localization of the disease and the peritoneal cavity for ovarian germ cell can also impact on the capacity to have a better treatment, considering that for testicular, more frequently, it is only the lymph node evolution. Considering the new treatment, we have some good news with EDC, and particularly the Claudin-6 group, where we know that there is a huge overexpression in testicular cancer. And the good news is that we have seen some pharma company who try to explore this option, and the trial will start soon for testicular first. But I think that if we see something interesting, we will, I hope, jump in for ovarian.
Excellent. Well, thank you. Great start to this discussion. And from germ cell tumors, we're going to move over to the sex core stromal tumors. Elise Yates from Houston Methodist.
Thank you all for your time today. My question is for For relapsed ovarian sex cord stromal tumors, is there any role for the addition of bevacizumab in this population? Thank you.
Take it away, Isabelle.
Thank you very much for this question. You're right. Jubilee Brown and the US team first report the activity of BEV in this disease. We explored the BEV in combination with the weekly paclitaxel in the Alienor trial. It's a randomized trial, and we are very proud to have conducted such trial at the worldwide level. Europe, but also Japan participate. And in this trial, if we see a better response rate adding BEV to weekly paclitaxel post-platinum-based chemotherapy in the sex cord tumor, including adult granulosa, but also sertoli Leydig. Considering the PFS and the overall survival, we don't see any difference. So we have to be cautious with what I'm saying because the number of patients were small and perhaps a longer follow-up and more patients can be able to make the demonstration. But right now, we don't see a difference in terms of PFS. So how we decide in Europe and in France to use this combination is when we consider that a reduction can increase the chance for the patient to get surgery, because you know that in the relapse setting that the best friend for a sex cord tumor remains the surgeon. So we are using the combination in this case, but if not, as it is an indolent disease, we don't move systematically in this combination.
Great. Any additional comments from David or Jonathan on that question?
Not for me.
I would say that, you know, although it hasn't been studied, in metastatic granulosa cell tumors or even Sertoli Leydig cell tumors, frontline, you know, there's always the question about BEP versus paclitaxel carboplatin. We tend to use carboplatin and paclitaxel. And, you know, you could question whether there should be an integration of bevacizumab into that combination, both in the newly diagnosed metastatic setting and in the recurrent setting if they've not already been treated with that combination. But that really hasn't been studied yet.
Yeah. And for our international listeners, when Dr. Gershenson refers to BEP, is bleomycin etoposide platinum. We tend to use lots of acronyms here in the US. But also wanted to follow up a question on that, David, if you can speak a little bit about role of hormonal therapy in the setting of patients with granulosa cell tumors.
Yeah, certainly there's evidence that hormonal therapies, particularly aromatase inhibitors and tamoxifen, and even depolupron, fulvestrant, may be active in these patients. I think to date, we don't really know how best to use them. They are used in many different settings. So some will start them after primary chemotherapy for metastatic disease as a maintenance therapy even, and that there's, again, no evidence I'm aware of, and certainly no randomized evidence. Some, they will frequently be used in recurrence because, you know, most of these granulosa cell tumors, for instance, have FOXL2, but it's not targetable, it's not actionable, and we don't really have any great targeted therapies yet for this disease. And so hormonal therapies are frequently used in the recurrent setting as well, and some patients do respond.
Excellent. Very, very well. So next question comes from Matteo Marchetti, University of Padua. And I think he's directing this question at David and Jonathan. Matteo.
So thank you. Given the title, the topic of the special issue is rare gynecological cancer. And one of the problems is the lack of strong evidences in these tumors. What do you think is the best strategy to gather stronger evidence for best strategy for surgical treatment for example, rare ovarian cancer, PDS or EDS? And should we focus on international registries, or there is a hope for conducting clinical trials in rare ovarian cancers? Thank you.
Shall I kick off? I mean, this is a non-surgeon's view, because I'm an oncologist, but that doesn't stop me from having a strong view. I mean, I think the first thing to say about IDS, PDS, these are different diseases from ovarian cancer, and I think it's really important that we understand that even resection of disease that is not to no residuum is probably better for many of these tumors than no surgery at all. And we've seen this, typically with low-grade serous cancer, where neoadjuvant chemotherapy has really very little effect, and yet there's a real importance of conducting surgery, performing surgery in these patients, even if you can't cytoreduce them completely. If that was a standard epithelial tumor ovarian cancer, you'd have a very different view. But to sort of really address your question as to how we should research this, it's been hard enough to do all these types of surgical trials in epithelial ovarian cancer. So in these rarer subtypes, it becomes even harder to do. So I think good quality registry data is a very good way forward. And we're fortunate now that increasingly all the data that we collect, the clinical data that we collect, is electronic, and electronic records are easier to interpret, to get the data out of than handwritten charts, notes. And furthermore, we can use AI to actually read text and to then use that to translate that into terms that could be entered into a database. So I think the collection of really well-conducted real-world studies is going to be very helpful to try and identify, for example, how we should best treat some of these rarer tumors surgically.
Yes, I would definitely agree with Jonathan that registries are the way to go. I think it will be very challenging, if not almost impossible, to conduct randomized trials in this area for these rare tumors. I would, I think primary cytoreductive surgery is always the preference if it can be done, if you think the tumor is resectable, or even if you think you can remove most of it, or unless they have comorbidities, it would be another reason for neoadjuvant treatment. It's pretty well established that for low-grade serous ovarian cancer and mucinous cancer, they're not very chemosensitive. And so really there should be an emphasis on primary cytoreductive surgery. However, I think there are a couple of things to mention. Number one, I think we've missed the opportunity at least in the US, I think they do this a lot more in Europe, and using bevacizumab in combination with chemotherapy. And I think the response rates are higher, even in something like low-grade serous ovarian cancer. Also, it's important to point out that there are a couple of novel strategies that are being studied. One of them is to use hormonal therapy, endocrine therapy for neoadjuvant treatment, and a trial that was reported at ASCO a few years ago from our group, from Lauren Cobb, showed that there was a 60% response rate in a pilot study of 15 patients treated with fulvestrant and abemaciclib. Another group is studying MEK/RAF inhibitors combined with letrozole in the neoadjuvant setting. And we could maybe think of other novel treatments, possibly for mucinous carcinoma. But I think it is an evolving landscape, but if we can, the preference should always be, I think, for primary surgery if it's feasible.
Yeah, and one additional point I think is also, Matteo, with regards to, these rare tumors are typically not the types of tumors that are presenting with advanced stage disease as the typical epithelial ovarian cancer. So they're often characterized by presenting with the single adnexal mass. So therefore, the question of primary versus interval debulking surgery is not really impacting the whole schema of how these tumors are being treated. But yes, nevertheless, obviously, in that setting where the patient has advanced disease, that becomes a topic of debate and discussion. So with that, then I'll turn over to Christian Brown, Lucerne Hospital. Christian.
Yeah, thank you for putting together this very comprehensive special issue. My question is about synchronous primary endometrioid carcinomas of the uterus and ovaries. So based on the current evidence, which molecular characteristics are the most reliable for distinguishing advanced endometrial carcinoma with ovarian involvement from true synchronous primary tumors?
Who wants to take this simple question?
Isabelle? Yes, if you want, because in the GCIG Conference of Consensus last year, we published a paragraph on that to be very clear how to manage this case. And finally, what we consider is to reproduce the molecular classification on both tumors, that mean in the endometrial and also in the ovary, to try to see if we have the same molecular profile to consider the same disease. If we see some difference, to consider that it is two different disease.
So now,
Lancet Oncology, Karen, first author.
I was going to say that. Perfect. Jonathan, David, any?
Yeah, no, I think that's. I mean, I think we've got now many more tools to study these tumors and to try and get a fingerprint, as it were, of the tumors, not only from more standard immunohistochemical analysis, but with NGS as well, and can see whether some of the mutations that occur are matched in the two tumors or not. I think it's an issue not only for the endometrioid tumors, but it's also an issue for the serous tumors of the endometrium, which we sometimes don't know whether they've originated from the ovary or from the endometrium. So I think in addition to very careful analysis of the standard histopathology and, for example, tumors that penetrate deeply into the wall of the myometrium are probably more likely to have originated from the endometrium than the ovary. But so taking that into account, and then the immunohistochemistry and the molecular analyses, it still can be difficult in the end, but I think it's a little bit easier than it was 5 years ago.
Yes, I would just add that patients with synchronous primaries are generally younger and have earlier stage disease. I think if you look at these as a whole, the majority of patients have disease metastatic from the endometrium to the ovary. And as Jonathan and Isabelle said, NGS certainly helps us to distinguish these two entities. I think there's also evidence, as mentioned in the Pignata article in our special issue, that synchronous primaries more frequently have MLH1, PMS2 deficiency, and PTEN aberrations. So that's another key to differentiation.
Excellent. So thank you, David. And I love this question from the audience, Alisa Chevat. I hope I pronounced your last name correctly. And she says, I think a challenge is also motivating patients with rare tumors to participate in research. Any advice from you as to how do we encourage and improve participation of patients with rare tumors in clinical trials? Jonathan, I'll start with you.
Yeah, actually, I don't think it's the patient. I think it's the doctor. I think the patients are really very keen to participate in trials. They understand they have a rare tumor for which there are no standard or very few standard treatments, and if there's an opportunity to participate in a trial, they will jump to it. I think the difficulty is the doctors, in the sense that not that they just are resistant to clinical trials, but because the tumors are rare, they may not have them open in their hospital because it's just not worthwhile going through all the procedures to do that, and they may not feel comfortable with referring the patient to another center where that trial is going on. So that's where I think the issue may lie. But Isabelle, you have the great experience of networks and rare tumor research.
No, I completely confirm what you are saying, Jonathan. In France, where we have this network where the patient should have to receive the second opinion in terms of histology and discussion in terms of the multidisciplinary tumor board, all the patient and the patient advocacy group who work with us told us that it's not a question of patient. All of them would like to participate to all the trial available. And just to give you an information, we have right now in the adult granulosa cell tumor, something that could be very interesting is a TGF-beta inhibitor. And we know that FOXL2 and TGF-beta have a cross interaction. In this trial lead by AbbVie, we have seen 4 partial response with adult granulosa cell tumor. So we opened the trial in France, adding the patient advocacy group in the loop, and we were able to include 10 patients, I think, in less than 6 or 8 months because of the communication with patients. So I think that really Jonathan point an important topic that we need to motivate more the physician than the patient because the patients are already motivated.
Excellent points. David, anything you'd like to add?
No, I not really. I think they've covered it.
Excellent. Very well. So now we'll turn to a very rare cervical cancer. Clara Santia, who's here with us at Houston Methodist, is going to ask that question.
Perfect. Thank you, Doctor, for showing us today and for sharing your experience. We really appreciate it. My question is about neuroendocrine cervical cancer. What role does immunotherapy currently play in the treatment of your patient diagnosed with neuroendocrine cervical cancer? Do you use it in locally advanced cervical cancer despite the fact that patients with this diagnosis were not included in Keynote A18? And also, what role does immunotherapy have in advanced, progressive, or recurrent cases? Thank you.
Well, Isabelle, you want to start?
So you're right, these tumors have frequently a high PD-L1 expression. So we can suspect that immune therapy can bring something for this patient. And there is some, I don't remember any dedicated clinical trial, but I have seen several case reports in the literature who report that immune therapy, PD-L1 or PD-1 inhibitor in combination with chemotherapy can bring something. However, there is no randomization, so it's always very complicated to know. And more specifically, without randomization and adding the fact that this tumor are sensitive to platinum-based chemotherapy, cisplatin plus etoposide gave good response rate at the beginning, is very complex. So to say that in the first-line setting in my country, we did not have systematically Pembro, because right now Pembro is not available. It's just in the accelerated approval, and in this case is dedicated to the inclusion criteria of the clinical trial. However, in the relapse setting, some of us try to explore, but there is no strong data to confirm until now.
Yeah, I think the article by Salvo and colleagues explains it pretty well. There have been recent FDA approvals for Pembro plus chemotherapy as first line for metastatic recurrent cervical cancer in general, and for FDA approval for second line Pembro. But of course, the neuroendocrine cervical cancers are rare. I only know of case reports or small series, but there are some reports, for instance, of patients having nice responses to nivolumab or nivo-ipi combination. So I think we will see immunotherapy be utilized increasingly in this cohort.
Yeah, I mean, it's difficult, and it's also difficult to know, which types of patient are going to respond. I mean, again, the information is from the case reports, and it's not clear from my reading of those reports that the expression of PD-L1 indicates whether or not the tumor is going to respond. So, I mean, I wouldn't use that as a reason not to try it. And I think in a situation, particularly in the recurrent setting, where patient's gone through more standard chemotherapy, that is probably where I would at this point use it. I think it's a big step to take it forward into frontline treatment without us collecting more information. But here again is a case in point where, you know, collecting good registry data, or through the networks such as the French networks that have been set up, you can build up a database of patients who've had various treatments, chemotherapy treatments, various immunotherapy treatments. What's the outcome of these patients? That is the way that we're going to build that information up. It's not going to be through randomized trials in neuroendocrine cancers of the cervix.
Yeah, and Jonathan, I'm very glad you actually did mention that, because I would like to add that, you know, to one of the greatest achievements for Michael Fromowitz in the studying of neuroendocrine carcinomas was establishing the NECTAR database and the network of not only scientists but also patients being involved in their own care and research. So we always will be very grateful to Michael for developing that, and what became known as the Texas cocktail. That, you know, certainly it was a combination that was unique for these types of tumors. I believe it was platinum etoposide, irinotecan, and this is something that, you know, we always often used to talk about it at Anderson tumor boards with regards to the Texas cocktail. I don't know if they call it the Texas cocktail in France or in the UK. But
we can say the Fromowitz cocktail, because you're right.
Yes. Well, thank you for that. And thank you, Clara, for raising that question. So next we go to Valencia, Spain. Manel Montesinos Albert, your question.
Hi, thank you. My question is about the management of uterine serous carcinoma. How does the response rate to trastuzumab differ between first diagnosed and recurrent HER2 positive patients?
Okay. Jonathan, you want to start?
Yeah, so thanks. That's it. I mean, you know, it was very intriguing data that we saw. I mean, it was a randomized phase 2 trial. There's not, you know, we need more data out there. And I think, you know, as I remember from Amanda Fader's paper, the number of patients who had recurrent disease was relatively small. Most of those patients were advanced first-line patients. And actually, I think the response rates when trastuzumab was added to the chemotherapy was not particularly higher. In fact, I think it was lower, a little bit lower for what it's worth, than it was in the patients who didn't have trastuzumab. But the benefit was because of the maintenance phase with trastuzumab. And I think that's the important key with this agent, and indeed with many of the anti-HER2 agents, to sustain the response, to sustain the clinical benefit.
Excellent. Isabelle?
Just to continue on the discussion, what we have seen with using the antibody in combination with chemotherapy was probably completely different than what we will see with the TDXD, which is the antibody had a conjugate with the payload. And so I don't know how to interpret the data with the antibody alone, but I'm sure that for the TDXD, the problem will not be the same, because the response rates and the duration of response we have seen in the relapse setting is very huge. And the clinical trial starting soon in localized disease, in first metastatic disease, and in the relapse setting will give us the information.
Excellent. David, any additional comments?
No, nothing important to add. I think we'll continue we've got a number of drugs in this family, and we'll continue to conduct trials and learn the best approaches.
Excellent. All right, so now we go to Canada, Toronto. Stephanie.
Thank you. My question is, as the field of vulvar cancer research advances, do you think that margin status or pathological aspects such as HPV status, or maybe even a combination of both, will play a more important role in predicting recurrences?
Stephanie, thank you for the question. I know nothing about vulvar cancer anymore. However, Based on the nice article by Abba Rustam and colleagues in our special issue, we know that patients with HPV-related vulvar cancer are younger, and they generally have earlier stage disease, and we segregate these patients into HPV-related and non-HPV-related. We also know that margin status is very important, and that having a margin of at least 8 millimeters is really, really key. And both of these features are associated with a more favorable prognosis, but I'm sure Pedro can give a much better answer than I can.
Yeah, my level of expertise in that area is about 1/10 of yours. So definitely appreciate it. Isabelle, any comments?
No, I think for vulva it's really the beginning, and we need to really develop what we said before in terms of prospective data and put more biology, because for me it's completely different disease, looking to HPV and the other, and we definitively need to develop this registry to better answer to your question.
Excellent. Well, thank you for those comments. And now we go on to a topic that we can probably dedicate an entire podcast to. Low-grade ovarian cancer. Is it truly a rare tumor? So for that question, Julia Yellison from the University of Wisconsin-Madison.
Dr. Gershenson already touched on this a bit before, but I was wondering what treatment strategy is under investigation right now for low-grade serous ovarian cancer you think have the greatest potential to impact outcomes for these patients, especially for those with advanced and unresectable disease.
Oh, thank you, Julia. So a few things. I alluded to bevacizumab, and that I think, at least in the US, we haven't taken advantage of the opportunity to utilize it. Both, we know in the recurrent setting, 2 retrospective studies showed that the response rates are 40% or greater. It hasn't been integrated into frontline therapy or neoadjuvant treatment as much as it should have been. Of course, we know that treatment for newly diagnosed patients is undergoing a treatment trial, a trial right now, a phase 3 trial comparing chemotherapy followed by letrozole maintenance versus letrozole monotherapy. That's a non-inferiority trial. Once we have an answer, if there is a difference, and let's say, well, if there's not a difference, if that the letrozole monotherapy is not inferior, then it will replace chemotherapy letrozole altogether. And then other strategies will move into the frontline setting. And some of those are being studied in the recurrent setting. So a couple that I think are important. One is the combination of endocrine therapy plus CDK4/6 inhibitors that are, the CDK4/6 inhibitors, of course, are FDA approved for breast cancer, but not for ovarian cancer. And in a phase 2 trial, we've shown a 31% response rate in that group of patients. Also, we conducted a neoadjuvant study with fulvestrant and abemaciclib that I briefly mentioned, and that had a 60% response rate in a small number of patients. So those are a couple strategies that I think need to be continue to be studied. The other ones I would briefly mention are mirvetuximab. We know that 20 to 40% of low-grade serous carcinomas have a positive folate receptor. And I think we need to gain more experience in the use of mirvetuximab in this group of patients. And then I think, we've got a lot of KRAS specific inhibitors, KRAS G12D inhibitors and other inhibitors. So lots of good news, I think, in the area of new drugs.
And David, as a follow-up to that, I wonder if you can give us any updates on the accrual on that trial that you mentioned, which I believe is the NRG GYO19. Yeah, so how is accrual going? Is there a hesitation to actually just put patients on letrozole after surgery?
No, not really. So good news. The trial is designed for 450 women. It will complete accrual in May or June of this year. So in 2 or 3 months, it will complete accrual. There'll be another interim analysis conducted this summer, and we'll see. And then, of course, we may well need to wait longer to see the results, but very, very exciting. And the trial has accrued extremely well. And it just goes to show you these patients are very motivated to participate in clinical trials. So it's a little hard sell because, you know, when you're looking at a randomization of chemotherapy versus no chemotherapy, I've had a number of patients who just can't quite go there, and they want to just make their own decisions, which is okay. But the accrual's been excellent regardless.
Excellent. So then we have our fellow at the Medical University of Vienna, Thomas Bartel. Leave it to Thomas to always ask the shortest question. Thomas?
Thank you. I would actually like to address the choice of cytotoxic chemotherapy in advanced or recurrent mucinous ovarian cancer. So efficacy data in this setting is extremely limited, and there's actually no validated therapeutic standard of care for recurrent disease. So after the failure of the IJGC 241, current ESMO guidelines refer to platinum-based chemotherapy as a single standard of care. However, to my knowledge, some centers such as, I think, the MD Anderson, routinely also use gastrointestinal chemotherapeutic protocols, and also with quite encouraging results. And also the NCCN guidelines offer Capox and Folfox as alternatives. So how do you see the use of gastrointestinal chemotherapeutic protocols as compared to the standard of carbotaxol, especially in case of disease recurrence?
Excellent. So, Jonathan, you want to start?
Well, David and I spent many, many years trying to run, actually it was a collaboration between the GOG and the NCRI, which is the UK group. It was called the MEOC trial. So it was a collaborative venture to really try and do a randomized study looking at gastrointestinal chemotherapy versus more standard gynecological cancer chemotherapy. And we failed because we failed to recruit. And we failed to recruit for a number of reasons, some of which we sort of discussed in one of the papers in the series. But it left us in a situation where we really didn't know what to do for the best. And that trial actually also included the addition or not of bevacizumab. So we had a sort of factorial design to it. So it's a great shame that we weren't able to move the field forward. I think, you know, what many people do is to start off with carboplatin paclitaxel. I must say I do tend to use bevacizumab in these patients because they have such a poor response rate to cytotoxic therapy, and we know that with bevacizumab you can improve that, and we've seen that also in gastrointestinal tumors. And then if that's not working, or if the patient then has a progression, to switch to something like Folfox or Capox to use oxaliplatin. But you know, the real problem is that we don't inherently know whether these tumors really do behave more like a gastrointestinal tumor. And of course, a large bowel tumor will not respond to carboplatin. It doesn't. There's something different about that tumor that makes it respond to oxaliplatin, but not to carboplatin. We just don't know that sufficiently well for the mucinous tumors of the ovary. But I think the other strategy that I think we really need to follow through on is to move away from these platinum taxane or platinum 5-FU type combinations and look at other molecular markers in these tumors that might be suitable for targeting. And of course, one of them is the expression of HER2, which we know is really quite strong in quite a proportion of these patients. And so I think they would be a really good group of tumors to test drugs like TDXD and other HER2 targeting ADCs. So that I think would be probably the best way forward to try and improve the outcome of these patients who, when they've got recurrent metastatic disease, are really very difficult to treat.
Yeah, excellent. David?
Yeah, no, I agree with everything Jonathan said. He and I have commiserated over the years at this failure. I also want to take the opportunity to mention one of my heroes, also Martin Gore, who was very instrumental along with Jonathan in developing this trial. We lost Martin a few years ago. He was a real icon in the area of gynecologic cancer therapies, and really miss him. So if you've never heard of Martin, look him up.
Yeah. Really outstanding. Isabelle?
Just to reinforce what David and Jonathan have said, and effectively, why we continue to use carboplatin paclitaxel is because sometimes it's request to include the patient in a clinical trial. So starting with FOLFOX or FOLFIRI can be detrimental for the participation to any clinical trial. So for this reason, we continue to stay conservative. And I agree that the HER2 expression is interesting. We had some time Herceptin to the combination of chemo. And we will report soon the activity of the TDM1 in the Bouquet trial, where we have tried to explore for patients with a molecular alteration as a mutation of HER2 or amplification, if this kind of drug could be interesting, knowing that TDM1 is probably less effective than TDXD, as we have seen in breast cancer.
Excellent. Well, I think this has been a really remarkable podcast, a Journal Club. Really appreciate the three of you joining us, David, Isabelle, Jonathan. Very, very grateful for your accepting our invitation to be the guest editors for the March 2025 special issue. I think everyone would agree this is a really outstanding special issue. I want to thank you all as well for your continued and lifetime contributions that you've given our field and our patients in the area of rare tumors. All three of you, certainly remarkable contributions, and we're so proud to share this space with you. So thank you for that.
Thank you. Thank you very much for having us. With pleasure. It was a pleasure to
Thank you very much. Bye-bye.
And I also want to remind everyone to join us for the April Journal Club to discuss our special issue with Nadim Abarostum on effect of substantial lymphovascular space invasion on the location of first disease recurrence in surgical stage 1 endometrioid endometrial adenocarcinoma. I also want to thank all of our fellows for submitting their questions and participating in this discussion. Thank you so much, everyone. Until next time.
Thank you. Bye.